Good day, everyone. This is Chris of the Ancient Scholar. Today I'd like to go ahead and start a discussion discussion on ventilation. And this discussion is actually relates to a online discussion that I've been having on a nursing forum regarding ventilation and the role that carbon dioxide and oxygen plays in this stimulus to breathe. So there are actually several misconceptions that go on in healthcare. It's not necessarily a misconception so much as not being able to appreciate the complete scope of what is occurring physiologically. So the first misconception is a misconception that occurs among the general public, people that are not healthcare providers. And the misconception is that if I take a breath and I hold it, and I continue holding my breath, I begin to develop an uncomfortable feeling. This feeling is very uncomfortable. I get a little anxious, I get a little panicked, and I want to take a breath. And the longer I hold my breath, the more and more uncomfortable this feeling becomes until my brain basically overrides the autonomic part of my brain, if you will, the self-preservation part of me, overrides my conscious self, and I'm essentially forced to take a breath. A lot of people that have no medical background would probably think that this is because our oxygen level gets low. As we hold our breath, our body senses the oxygen is becoming low, and it causes us to take a breath. That is, in fact, not typically the case, and we know that our oxygen levels have to get exceptionally low before ventilations are triggered. Fair enough. So the second misconception is a misconception that comes from the medical community, actually. I see this quite a bit among nurses and hospital professionals. And their misconception is, let's go back to the same scenario where I hold my breath and I begin feeling anxious and I want to take a breath. In a lot of cases, what I hear them say is, oh, that's because your carbon dioxide level is getting high. And carbon dioxide is actually what causes us to breathe. When our carbon dioxide gets high, our brain tells the body to breathe so we can get rid of that carbon dioxide, blow it off. Well, here's the case. That is, depending on the context, at least partially true to some extent. But let's go ahead and look at this a bit more detail. My argument is that's not actually the case. That's not the case at all. Carbon dioxide by itself, okay, just carbon dioxide gas as it's being released from the Krebs cycle by itself really doesn't do anything other than it's a gas and it exerts a certain pressure and so on. Okay? So carbon dioxide by itself really isn't a stimulus to breathe. Okay? So let's go ahead and look at the brain and what do we have in the brain as far as, we have breathing centers, of course. Several different breathing centers, but what we have is we have receptors in our brain. And what these receptors do is they monitor the chemical environment of the brain, specifically the chemical environment of the cerebral spinal fluid as it circulates in and around our brain. And the specific set of receptors that I'm interested in are what we call the central chemoreceptors that monitor the pH. Let me say that again. They monitor the pH of the cerebral spinal fluid. And it is in fact the pH of the cerebral spinal fluid that acts as the primary drive to breathe, as a primary stimulus to breathe. If you don't believe me, I want you to imagine a patient, or imagine this scenario that should help clarify that a little bit. Imagine you have a patient who is in diabetic ketoacidosis, okay? We run an arterial blood gas on that patient and we note that their carbon dioxide is very low. Maybe the carbon dioxide is 18 millimeters of mercury, okay? It's exceptionally low, and 35 to 45 is considered the normal range, with 40 being a normal value, and obviously a couple of standard deviations above and below that gives us our range. So clearly that's quite low. However, if we look at the pH of that patient is probably going to be very low. It's going to be quite acidotic. So if you still believe that carbon dioxide is a primary stimulus to breathe, you now have a dichotomy that you must explain. You have this dichotomy in this DKA patient where their carbon dioxide is very low, so they shouldn't have a particularly aggressive stimulus to breathe, should they? Their carbon dioxide is very low, and if we think that carbon dioxide is a primary stimulus to breathe, then a patient in diabetic ketoacidosis should not have much of a stimulus to breathe. However, in a lot of cases, patients experiencing DKA are breathing very rapidly, very deeply. This is, of course, the classical, what we call Kussmaul's respiratory pattern. So clearly there's something going on. And if you look at the theory which I presented, which was a pH-based theory, you'd realize that pH easily explains why this patient is breathing so quickly and deeply, and that is the fact that the pH is very low. The chemoreceptors are sensing a very low pH, a very high acid environment, and they are triggering a respiratory response. Okay. Likewise, let's go ahead and think of another type of patient, and this is, let's say we have a patient with whatever type of chronic obstructive pulmonary disease you want to give them. Say they have it, and let's say that they are a chronic carbon dioxide retainer. Okay, they chronically have high CO2s. Okay, so we take this patient, and let's say that this patient is relatively stable. Okay, they have COPD, they've had it for many years, it's not a big deal, they manage it very well, and for the most part they do okay. Obviously they probably have some limitations to their ADLs, but they're alert, they're oriented, and they don't typically experience significant respiratory distress. Okay, so we run an ABG on this patient, and we notice what? Well, we notice that carbon dioxide is very high. And we say, well, that patient is running off of a hypoxic drive. The body has gotten used to that carbon dioxide being high, and instead of carbon dioxide being the stimulus to breathe, it's low oxygen, the hypoxic drive scarecrow, as I like to call it. Well, let's go back to the pH. What happens in a patient that has chronic issues, we'll say pulmonary-wise? I don't want to give it away quite yet, but let's say that they have some sort of chronic issue. Well, they compensate, right? And if you were to look at this patient, and assuming they're not in acute distress, you would notice that their bicarbonate is in fact very high. They have renal compensation. And if you look at their pH is probably going to be in a normal range. Okay, it might be a little, 7.342 or something like that, or 7.352, excuse me, 7.352 on the normal side of acid, but they will be in the normal range. Again, it's not the carbon dioxide that's a stimulus to breathe, it's the pH. In that case, that patient's pH is normal, so in spite of them having a high CO2, they're not running around hyperventilating all over the place. Okay, so if you're willing to accept those scenarios and accept what I've given you so far, we can hopefully accept that pH is the primary stimulus to breathe. So let's go back to carbon dioxide. First of all, what makes our pH low or our acid high? Well, hydrogen, right? Hydrogen ions, or hydronium ions, because generally hydrogen ion isn't going to float around in the body by itself for too long before it gets associated with a water molecule, and when that happens we call it hydronium, or H3O. H plus H3O proton basically all mean the same thing physiologically, but probably hydronium is the better way of looking at it, because that's what's more likely going on. Okay, so let's just go ahead and clarify this CO2 thing. Why, when we find high CO2s, do we typically find patients that are trying to maybe breathe faster? Is it the CO2? Well, yes and no. First of all, carbon dioxide is not an acid by itself. It's not an acid by itself. You look at carbon dioxide, there are no hydrogen atoms in that carbon dioxide molecule. It's CO2. But, and here's the interesting thing, carbon dioxide is because carbon dioxide is a small it's a small atom, it's a small molecule. It's not really polar, and while it can dissolve in water better than certain other molecules or gases, it doesn't dissolve particularly well. We have to do something to carbon dioxide to transport it in the body. And what we do is we convert carbon dioxide into an acid. Okay? So carbon dioxide by itself is not an acid. But what we do, and you guys maybe remember the horrors of having to learn this stuff at school, when I have carbon dioxide in an aqueous environment with water, so H2O plus CO2, I have an enzyme called carbonic anhydrase that helps catalyze this reaction. And in this case, water molecule and carbon dioxide can combine to form something called H2CO3, or carbonic acid. Okay? We know that carbonic acid isn't particularly stable, and carbonic acid will rapidly dissociate into a hydrogen ion or hydronium ion and a bicarbonate ion. So it will rapidly dissociate into its conjugate acid and base, and this is how we transport most of the carbon dioxide. A little over 80% of the carbon dioxide in our body is turned into hydrogen ions and bicarbonate ions. And then these, of course, are polar because they're charged. They can easily interact in an aqueous environment and via the circulatory system can be brought to the lungs, where, as you see this arrow here, not only do I have an arrow this way, but I have an arrow this way. So in the tissues, at the cells where CO2 is being produced, this chemical equation moves this way. And then once these guys get to the lungs, I have carbonic anhydrase again, and the chemical reaction then moves this way, where hydrogen ions, bicarbonate, can combine to form H2CO3, and then H2CO3 then breaks down into CO2 and H2O. The CO2 diffuses across the alveolar capillary membrane and hopefully out of the lungs. Okay, so in conclusion, carbon dioxide is not the primary stimulus to breathe. However, generally when I have high levels of CO2, I'm going to have lots of acid being produced because carbon dioxide is converted into something that is acidic. So CO2 by itself is not the primary stimulus to breathe, but in a lot of cases, carbon dioxide is turned into an acid, and of course that then can decrease the pH of our blood, and that then can act upon the central chemoreceptors in the brain. So it's kind of a slippery slope when people say that CO2 is a primary stimulus to breathe, because it really isn't until it's converted into something that is. Okay, and I think that's the big step that we often fail to make, and we teach